So suppose you take a BP of 100/70 or a BP of 90/60 and a BP of 100/84. Even if you see 90/60, we think it is hyper, but 90/60, this 90/60 BP has got a better prognosis than a blood pressure of 100/84 because the pulse pressure is narrow. So if the pulse pressure is less than 40, in the range of 20 to 30, it indicates it's compensated shock. Pulse pressure is systolic blood pressure minus diastolic blood pressure. In hypotensive shock, usually the pulse pressure will be less than 20. So compensation, decompensation, by measuring blood pressure, we all can make out the difference. And sensorium will be maintained in compensated shock. By the patient goes into decompensation, usually there is, patient is restless, lethargy, there's an altered mental status. Now the convalescent phase or recovery phase, what is going to happen is, here the endothelial, like how I said, the endothelial mechanism, whatever is happening is a reversible mechanism. So it becomes normal. So whatever fluid has gone into third phase, it's coming back into the circulatory system. The signs and symptoms improve. This phase occurs after the critical phase, and this usually lasts for 2 to 3 days. And the patient develops sometimes a convalescent rash. You usually see in palms and feet, and often pruritic. Patients with severe shock may take some more time for recovery. So this is just to sum up the clinical manifestation. So symptom-wise, clinically, the patient will come with high-grade fever, rash may be there, headache, retroorbital pain, myalgia, and arthralgia. Warning signs: recurrent vomiting, pain abdomen, dyspnea, change in sensorium. Hemorrhagic manifestations in the form of petechial spots, purpura, ecchymosis, like major bleeding spots, epistaxis, hematemesis, melena, hematuria. Signs clinically, they may have hepatomegaly, abdominal tenderness. In some patients, those who are having persistent vomiting and pain abdomen, most of the time they'll be having cholecystitis, A calculus cholecystitis, which usually recovers with the dengue infection. Pleural effusion, ascites, and tourniquet test will be positive. I'll be describing what it is. Plasma leakage in the form of pleural effusion, ascites, hypovolemia, shock, hypoproteinemia. It's a clinical, it's a lab finding. Now, classification. So again, why the need for classification is any situation where we are, this is if we get lot of cases together, if we're getting dengue as an epidemic, what happens is there's a lot of cases coming together. We have to triage them into those who need more care, those who can be sent for home care. So based on that, we have dengue classified into 3. That is mild, moderate, and severe. Mild is A, moderate B, severe is C. So A, again, we can classify it as A1 and A2. A1 is without risk factors. So patient with fever, with all fever, body ache, retroorbital pain, rash, but normal platelet count without any complications, no capillary leakage. A2 is same A1 symptoms, but they are having risk factors also. Moderate dengue is when the warning signs are there. B1 is normal individuals with warning signs. So that is, they have persistent vomiting, abdominal pain and tenderness, bleeding manifestations, syncope, ascites, pleural effusion, lethargy, hepatomegaly. There is increase in hematocrit and decrease in platelet count. B2 is B1 with comorbidity and high risk factors like infancy, old age, comorbidities, hemoglobinopathy, immunocompromised individuals. Severe is type C, in which C1 is severe plasma leakage. So because of severe plasma leakage, patient comes with hypotension and shock. C2 is when they have severe bleeding. C3 is with multi-organ involvement. So this is the same thing what I have told. Only thing, the points to be remembered in this slide is, so mild dengue, home or OPD management, follow-up and observation is enough. Moderate dengue, again, close monitoring. If needed with comorbidities, we can go for hospitalization or observation is enough. And type 3, that is C, severe dengue, all C1, C2, C3 needs management at a tertiary level. And another important point of knowing this type A, B, and C is when you're following and monitoring, you have to know whether your patient has moved from A to B or B to C. And referral should be done accordingly. Then what are the other multi-organ involvement with dengue? CNS involvement in the form of encephalopathy, encephalitis, febrile seizures, intracranial bleed. See, with the better and better fluid management and also with the appropriate referral, we have been able to reduce the mortality of dengue to a very large extent. Now the mortality is only 0.1%. And one of the causes for that is the diseases like encephalitis. So encephalitis, myocarditis, all this can cause high mortality, which is at times it's part of inherent viral infection. So we can't do much about it. But with an appropriate fluid management, with appropriate recognition of sick patients who are going into shock and hypotension, we can definitely reduce the mortality because of that. So CNS involvement, GIT involvement, they can have acute hepatitis, fulminant hepatic failure. Again, this is dengue patients with the liver enzymes of more than 1,000. They have a very poor prognosis. Cholecystitis, cholangitis, acute pancreatitis, other GI involvement, renal involvement in the form of acute renal failure, hemolytic uremic syndrome, and acute tubular necrosis. Cardiac involvement, they can have cardiac arrhythmia, cardiomyopathy, myocarditis, pericardial effusion. So patients with dengue coming with symptoms of syncope, palpitations, chest pain. When you see they are having tachycardia, which is disproportionately higher than their temperature. Again, they are having hypotension. Always we have to suspect myocarditis. Respiratory, pulmonary edema. Pulmonary edema can be a complication of overfluid management. Pulmonary hemorrhage is a part of dengue coagulopathy. Pleural effusion, again, as a part of capillary leak. Eye, they can have conjunctival bleed, macular hemorrhage, visual impairment, and optic neuritis. Musculoskeletal, they can come with myositis, rhabdomyolysis. Lymphoreticular system, infection-associated hemophagocytic syndrome, HLH, ITP, spontaneous splenic rupture, lymph node infarction. And others, this category is also very important because this will be the thing which you will be dealing with after the fever subsides. Also, they have this post-infectious fatigue syndrome. Some patients may have depression, hallucination, psychosis, and alopecia is also a problem. One of the recent mortality in dengue fever was because of associated hemophagocytic lymphohistiocytosis. So the various differential diagnosis, these are the differential diagnosis which we have to keep in mind. See, today's session on dengue and lepto together, because this comes under short febrile illness without a specific localization. So leptospirosis also we should always have in our mind. Malaria, chikungunya, enteric fever, then rickettsial infection like scrub typhus. So how you are going to analyze or go about a patient coming to you? So when a person comes with fever, date of onset of fever and illness, then whether the patient is taking enough fluid, whether there is any diarrhea, urine output, whether it's reduced, assessing of warning symptoms, change in mental status. And other important relevant history is in similar episode of cases in the neighborhood or travel to dengue endemic area, or whether exposed to flood. Such cases, you have to consider leptospirosis also. Then physical examination, this is there for all fever. It's not just for dengue, any fever patient. We have to assess the mental status. We have to assess the hydration status. Hydration status, you're going to assess. One is you ask the patient to show the tongue. So tongue is really dry. It indicates the patient is dehydrated. Then there are no tears, eyes are sunken, skin turgidity is lost. Assessment of hemodynamic status is another thing which is extremely important. We have to check for postural hypotension. You ask the patient to lie down, then get up if there's more than 20 millimeter fall in BP. It indicates that there's postural hypertension. Fundus examination, we can't do. Look for tachypnea, that can be done. Pleural effusion, definitely we can auscultate. Abdominal tenderness can be made for. Look for rash and bleeding manifestation and tourniquet test. So this is how tourniquet test is performed. We have to tie a BP cuff and the BP should be raised midway between systolic and diastolic. So if the BP is 120/80, you're going to raise the cuff pressure to 100 and keep it like that for 5 minutes. You have to select an area of 1 square inch and first see to it that there are no petechial spots there. Okay. And then after 5 minutes, when you can see the petechial spots developing. The test usually gives a definite positive result is more than 20 petechia. More than 10 is, we can consider it as positive. The test may be negative or mildly positive during the phase of profound shock. So if your patient has come in profound shock, at times this may be negative. So this is in the early phase, in the decompensation stages. there this test has got significance. So you have admitted the patient, you can definitely do it daily. So we have this probable case and confirmed case. In probable cases, in the epidemiological setting, with the history of fever, myalgia, headache, retroorbital pain, arthralgia, and you have done a card-based test. It could be an NS1 antigen or it could be an IgM dengue, which is positive. That is card-based test is positive. That is a probable case. Confirmed case is case compatible with clinical definition, plus you are isolating the virus, which is possible in the early stages. NS1 ELISA positive, IgM ELISA positive, or later on IgG seroconversion in paired sera after 2 weeks. There is fourfold rise in titer, which you usually don't do. Detection of viral nucleic acid by PCR, which is also not done usually for all patients. So this is a case scenario of a 33-year-old male who had fever for 3 days, rash over face and chest for 1 day, 1 episode of nosebleed, generalized body ache, holocranial headache, joint pain involving multiple large joints, retroorbital pain and weakness. So with this history suggestive of possible dengue symptoms. Patient had similar fever year back when he was diagnosed with dengue fever. So if he is already diagnosed 1 year back, now again we are suspecting, so this is a secondary dengue. He's not having any comorbidities. Gives history of fever in wife 7 days back, which resolved with over-the-counter antipyretics. Now his pulse rate is 118 per minute. So he's definitely having tachycardia. Respiratory rate is 26, which is high. Temperature is 101. See, his blood pressure is 104/92. So the pulse pressure is coming to 12 millimeter. He's having rash. Tourniquet test was positive. Respiratory system, there's decreased breath sounds in the infraaxillary area. So most probably he's having capillary leak and there is pleural effusion. So this is the X-ray of this patient. You can see the right side, there is pleural effusion. And the blood investigations, hematocrit is 68, total count is 3,800, platelet is 12,000, liver enzymes are 240, 495, urea is 94, creatinine is 1.9, some of a pre-renal picture because of dehydration also. Dengue NS1 is positive, urine, there is hematuria, chest X-ray, mild pleural effusion, ultrasonography, there is hepatomegaly. So as such, this is a case of severe dengue. So to sum up, approach of case of dengue, acute febrile illness of less than 7 days, day of fever, detailed history, warning signs and symptoms. See, I'm just keep on repeating this so that we don't miss it. This is the thing which you all have to see. Pulse, BP,